be a little bit confused if you don't know. For example, if patient come to consultation and say, I have pain in my joints and show fingers, you start thinking about rheumatoid arthritis and forgot about to check skin, for example, or check internal organs. That's why you always should be attention in patient with rheumatoid or rheumatological disease. Sometimes they might be but not sometimes. Often students disease confuse doctors. They can start by like rheumatoid arthritis because a lot of the disease you already noticed that they all have joint problems. That's why you can be confused by disease and mistakenly think about rheumatoid arthritis. Don't confuse. You should just remember about other symptoms of other disease. It's about joints. There will be morning stiffness, but not look like rheumatoid arthritis. There will be a general arthralgia. General patient can't found just hands. No, there might be arthralgia in knee, in neck, etc. And check by X-ray. Other organs, intestinal organs. Okay, intestinal organs. 1 second. Okay, and about other. 1 second, sorry again, D3. Intestinal organs yeah, I want to switch off your voice, but 1 second, I can't close. Okay, done. The intestinal organs mainly start from the esophagus. Patient noticed that there is some problems with esophageal part of the GIT. They complain to the some reflux. Of course, they can't say that they have reflux, but they explain that there is some problems and they can't eat normally food. And they feel pain. And when you start check this change, you found that there's due to stricture, there will be why stricture? Because sclerosis, fibrosis, there will be reflux esophagitis. And of course, due to this, there will be hypermobility. With stomach also might be same problems. There might be strictures, there might be fibrosis. Small intestine, large intestines also might be problems with obstructions because there might be paralytic. Okay, I switch off your voice without permission to on. If you have some question, please just show your hands. I will on your voice. And about small and large intestine, same problem. There might be obstruction, there might be paralytic ileus, might be impaction or chronic constipation. Patient have some problems with GIT. It might be small problems if there just esophageal reflux disease. There will be big problems if there is paralytic ileus or fecal impaction. That's why it's different from the stage and area of the GIT problems. But in 80%, I guess, in 80%, mainly affect esophagitis. There will be esophageal dysfunction. About the other part of disease, about lungs. Lungs often affected patient with systemic scleroderma. There might be, there will be fibrosis of lung. Of course, disease about fibrosis. That's why there will be fibrosis of lung. But if you remember in SLE, in rheumatoid arthritis, in dermatomyositis, also might be fibrosis. But more specific fibrosis for systemic scleroderma for visceral form and diffuse form. Okay, heart, there might be fibrosis of heart. If there will be a fibrosis of heart, there will be heart failure. There will be heart failure signs. And kidney also affected because fibrosis will be here. Why? Because kidney also they were reached by small arterioles. You know, we have two organs which reach by the small arterioles and vessels, first skin and kidney. That's why a patient with systemic scleroderma, they often have glomerulonephritis, glomerulopathy, different type of glomerulopathy. Clinical manifestation depend from which organ affected. If kidney affected, there will be gazotemia, there will be edema, there will be problem with urination. If affect heart by fibrosis, there will be arrhythmias, chronic heart failure sign, again edema, again dyspnea. If lungs, again there might be pain, dyspnea. If there is pulmonary hypertension, there will be again problem with breathing, etc. Clinical manifestation depend. All this clinical manifestation, I can't tell you because the clinical manifestation depends from the organ, which organ damaged. But we should know CREST syndrome. If you remember, before I said CREST syndrome, a more specific for limited form. Now we should discuss about CREST syndrome. What is it? CREST syndrome you can find CREST syndrome only in systemic scleroderma students, not for SLE, not for dermatomyositis, for systemic scleroderma. And what it means, you already know. I already tell about each symptoms. You know, complaints become to symptoms, symptoms calculate become to syndromes, syndrome calculate and become to disease. CREST syndrome consists from the symptoms: calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, telangiectasia. I just didn't say that these hands, which look like spider hands, it's also called sclerodactyly. Why? Because dactyls, it's fingers, yes, like this. Dactyls also called birds' fingers, if you know. Their fingers look like this, students. And patient fingers is fibrosis of skin of hands. In patient with systemic scleroderma will look like sclerodactyly. Telangiectasia, you know, calcinosis, you know, Raynaud's phenomenon, you know, esophageal dysfunction, you know. All these symptoms including CREST syndrome, more specific for limited form. In diffuse form, of course, there will be, but maybe there will be Raynaud, maybe sclerodactyly, but when you found all these symptoms, more specific for limited, okay. Okay, diagnosis. Before lab test, you know, it's criteria, you know, for each dermatological disease, we have criteria of disease. And, you know, criteria might include lab test, imaging test, clinical manifestation. Before in dermatomyositis, SLE, rheumatoid arthritis, they are included. But for systemic scleroderma, there is without lab test criteria. Of course, for diagnosis method to check lab test, but just for criteria is different. For diagnosis, lab test is different. Again, this criteria from American College of Dermatologists, they have one major and 2 or 3 minor criteria. One major is proximal scleroderma. Now pay attention. If you found proximal scleroderma, what it means? It means this patient have diffuse form, students. Diffuse form. If you remember, limited form affected distal part of body, skin. Diffuse form affected proximal also. That's why if you found one major, you can be sure that the patient have diffuse form. If you can't find major criteria, it means there's distal change or internal organs damaging without proximal scleroderma, it means in 90% limited or visceral form. In minor criteria, you can find sclerodactyly, you can find atrophy of the distal part of fingers, and bilateral pulmonary fibrosis. One major proved, or two or more, between three, also proved disease, systemic scleroderma. Now about lab test. Which here we said before, high specificity, 95% present of ANA, no problems. RF factor, rheumatoid factor, which was positive in rheumatoid arthritis, also might be positive in high percent in systemic scleroderma. I didn't tell about routine test, but you should remember always, we always check from routine test, students. This test is specific test. Topoisomerase antibody, antitopoisomerase antibody most specific for diffuse form. And anticentromere second antibody more specific for limited form. Even if you found some type of the antibody, you already can prove which type your patient have. If you are a little bit confused and can't diagnose which type your patient have, you can prove by test. And come back for this table. 1 second. This. Now everyone read. 1 second. Now everyone read, and I will explain. Now this test, this scheme for differential diagnosis, because why we should differentiate between diffuse and limited, because it's matter for treatment. If you diagnose diffuse, your treatment also will be except basic treatment. You should start your organoprotection treatment. We know it's more severe, dangerous form of disease, of this disease. That's why, first of all, you should correctly give which type your patient have, diffuse and limited. And you will check Raynaud's phenomenon. You will check antinuclear, which might be positive in both. Internal organs involving will be rare for limited form, rare renal, heart. Of course, for diffuse it will be more specific. Raynaud's phenomenon. Raynaud's phenomenon. Do you remember before I said Raynaud's phenomenon sometimes might be like individual syndromes for a long time, and it will be more specific for limited form. In diffuse form, if patient comes with Raynaud's phenomenon and fibrosis, it means diffuse because they usually start in one time. Lung in mainly, if you confused, you can check antitopoisomerase for diffuse, anticentromere for limited. But before this test, if you have not chance to check, use this differential diagnosis table, please, because it also will be informative for you. After when you diagnose patient with systemic scleroderma, you should start your treatment. How you will treat patient with systemic scleroderma? Sorry, laboratory test, you already understand what you should check. It's only about specific. Again, I repeat, don't forget to check routine, common blood analysis, common urine analysis, liver function, kidney function. All tests you should check in patient with autoimmune disease. About imaging test, X-ray, you can find calcinosis, ECG, if you think about heart